It's a very tough situation that you want to come live on Instagram. Mainly, I wanted to come live on Instagram to benefit the larger professionals. Let them at least get an idea that with the MPT. Okay, so they are because the enrolled participants. If we are holding the interaction in the Zoom, it will be only for us. So I wanted to hold this on the Instagram, but unfortunately, the Instagram is not helping our cause.
Yes, sir.
Yeah, this is creating a big tough time. Yes, our AI physiotherapist, Dr. Sujanya, will join when she can unmute the microphone. Is it okay? She thought when she speaks alone, she can unmute. All right, is it working?
Yes, sir.
It's really very, very. Is
Again,
it getting stuck?
your pic is very hazy. Again,
Audio is coming.
audio is.
Now, anything is better?
No, sir. Same. Voice is clear.
Okay, I'll just read out the report meantime and see that, the findings of the MRI report, multiple punctuate and confluent T2 weighted flare hyperintensities are seen in bilateral cerebral white matter without restricted diffusion, suggestive of age-related chronic ischemic lacunar demyelination. Acute disseminating encephalomyelitis, ADEM, will present like that. Among the demyelinating disorders, we have spinal cord, the transverse myelitis, ADEM affecting the brain. So these are all progressive degenerative disorders, neurodegenerative disorders. Ventricular system shows ex vacuo prominence with prominence of cerebral sulci, cerebellar foliae basal cisterns and sylvian fissures, suggestive of diffuse cerebral and cerebellar atrophy. The diffuse atrophy is usually suggestive of aging or cognitive deconditioning, which nowadays is very common because we use our brain only for particular things. We don't use it comprehensively. Other finding which is a note is made of left-sided mastoiditis. So there's a clear-cut inflammation of the mastoid, the bone itself. Polypoid mucosal thickening is seen in left maxillary sinus, which is suggestive of chronic infections, okay, sinusitis. Minimal mucosal thickening is seen in bilateral ethmoid sinuses, okay. So that may be more recent compared to the maxillary, which is more chronic. So the imaging reveals the impression. Finally, they have quoted as age-related chronic ischemic lacunar demyelination, diffuse cerebral and cerebellar atrophy, and no intracranial bleed, space-occupying lesion, or acute infarct is seen at present scan. The scan was taken on 28th April, which of course must be at least 1 week or within 2-3 days or maybe 24 hours, okay, mostly. Because the moment with the trauma, patient goes to the surgeon or doctor, okay, it's usual, customary that they do CT or MRI.
Yes.
You suspect a fracture, you can order for a CT scan. You are suspecting some kind of soft tissue or internal injuries, they might go for the MRI. So, as I was highlighting, the trauma is actually a clear-cut contraindication, okay, from a therapist point of view. Because you touch the skull for correcting the bones, we do not know that whether there is any fracture which is yet undiagnosed. Okay, because it's very difficult to diagnose the fractures of the skull. Okay, especially when it is in the base of the skull, and we are not going to benefit so much more than a risk of harm. Okay, the harm is always more than the whatever benefit you could bring, and at any scenario we do not want the patient to get worse. As a conscious therapist, we do not want patient to get worse. Okay, that's the first priority. And the second is we don't want the patient to medico-legally sue the therapist. Okay, that you touched and you did something and it became worse. So these things are emphasized in our courses, and we have already mentioned that as how we get the confidence of the physician, and then with the physician's permission and the guidance only we go ahead with the procedures. Okay, and I was highlighting that headache and then fall, so neurologist, fall and then headache is a neurosurgeon. It's not only for the headache, it can be vomiting, it can be olfactory, gustatory sensations, whichever. As a patient, if I have to think as a patient-centered perspective, okay, I want to think from here. Of course, the last webinar I initiated with asking Dr. Sujanya on her exposure with similar cases and what could she propose as a solution, because we have got the picture, one from the clinician, the history-wise, and we also have the MRI report. So let's listen to Dr. Sujanya before this internet or whatever happens. Okay. Yes, Sujanya? Yes.
So my main work with similar conditions post falls has been cranial sacral therapy, and there was a very similar case where I had somebody hit their frontal area, and the temporal was also a bit involved, and they had this bruise going on for a long time, and the reason she was not referred to a physiotherapist is because she had dizziness ongoing after the fall. So I spoke to this patient and over the phone just to let her know that how gentle this therapy is going to be if we are trying to regulate the CSF in the normal way and not being hard on your cervical joints, which also were affected due to the fall. There was a constant reason of her headaches being C1, C2 involved heavily, and she had sustained no fractures. So it is a very similar case, although she had loss of just I think one eye vision, like it was very blurry because of the blood clot that she had developed because of the fall, and it was very superficial, not interacting with her actual deeper nerves and any of the vision area. So it took a while though to clear up. So she was not recommended to see the physiotherapist, although she did it within 3 weeks of her fall. And I had to go through this cranial sacral work with her, and very gentle occipital and C1 area mobilization, which benefited her, not only getting rid of the bruise, clearing her eye, the blood clot that she had developed. It also helped her with clearing the vision, which kind of took in just 2 sessions, and she had cleared that. And also her breathing improved because she was very apical breathing after the fall. It really stressed her out. It opened a can of worms. All her stress stored in her life opened up. She was very anxious to drive back on the road, although this was just a fall while she was walking on a concrete path. But she could not drive because her blind spot on the right side was affected. So everything added up to the anxiety, and when we start treating the C1 area, it really reduced and brought her down. Her breathing improved, as Sir was explaining yesterday about the connection between the inspiration and expiration and the sacrum position at the bottom. It really, that was the mechanism in her. Her back pain disappeared, which also when we diagnosed, with a further assessment, these things came in. So my main area of treatment was C1 and suboccipital area. I barely did much work here because she was very tender. But after the second session, she did allow me to let her lie prone. And it was just easy, so she did not have any tenderness or soreness around this area. So it effectively worked. Her headaches disappeared. She was back on driving again from the third visit onwards. She kind of contradicted everything what the surgeon had told her, that she won't be able to drive for 10 weeks. But she went back again driving in 3 weeks' time, which was amazing. So it worked. Yay!
Okay. Okay. So this is one another illustrative example. Okay. So as theoretically we have to think, and what realistically it can happen. Okay. So one thing is the patient's ultimate trust. Okay. How much the patient actually trusts you, and the therapist's own inner instincts. Okay. It's like, for example, it is your gut feeling. What do you exactly feel that it will work? Okay. When you are treating so many patients, you have been addressing so many problems and dysfunctions, you will realize that I'll just touch there and see. And immediately after touching there, patient might feel the report that I am feeling little lesser, I am feeling much better. Okay. So you know that is the area to treat. Okay. That could be like anywhere in the body. Okay. So it could be cranial symptoms when it is present. It can be in the neck anywhere. It can be in the chest, even pulmonary. So, and these kind of, for example, traumatic, post-traumatic, always will have this vascular insufficiencies. Okay. So either it's a lymphatic one or it is the venous. And the sinusitis also affects the veins or lymphatic. Sinus, the fluid itself is a lymphatic fluid only. So it's all an interlinked one. And if we have to relate a bigger picture, it's where to start from. Okay, that is, it is like, it depends on which vehicle you are sitting at. If I'm sitting in the bus starts from one location to another location. Okay. If I'm sitting in the train, it starts from one location and it reaches another location. I am sitting in a flight, it also starts from one location and goes to another location. But you will never find the bus stand will be near to the railway station, and that will not be near to the airport. So there will be a huge distance between this bus stand, airport, and the railway station. So where I have to start means which one I am near to. For me, if the bus stand is closer, I'll go to the bus stand. If I feel that the airport is closer, I'll go to the airport. Railway station is closer, I'll go to the railway station. Not only this, the bus is usually cheaper, train is the medium range, and the flights are usually costly. Even if it is economy tickets, it's costly. So it is about the money part. Okay, so how much you actually either invest or patient spends, whichever. Okay, what all investigations you need for which whether the patients can afford. Every aspect comes there when it comes to money. Distance, it comes as what I have told is your assessment. Okay, when you are just touching, you might just touch the scalenes. Is it paining here? You might ask. Okay, and after that the patient will tell, yeah. Now I am able to feel the smell. Okay, it's like you cannot explain that, but it actually works. And after that you release the scalenes, and after that the subject might tell, yeah, I am able to feel much better. I am able to feel the smell. You'll be thinking olfactory, why it is. Okay. So these things are not explainable by neurophysiology. Okay. And in a simpler form, everything is connected to the brain. If you have a stimulus which is going from here, it is going to the brain only. A symptom which is from here also going to the brain only. Brain only is telling that this is my symptom, this is my problem. Brain only is telling that the place where you are touching is actually making me to feel better. So ultimately, all these are relayed by the brain. And imagine, as a patient-centered perspective, if I am a patient in this scenario, what will be my situation? Okay. At present, I do not know whether I have the smell sensation or not. Point blank. I do not know whether I have my smell sensation or not. I do not know at this moment, very moment, unless there is a strong smell, something of the LPG gas leak, which is like an emergency that comes. Maybe I'll think like, okay, yeah, I'm able to feel the smell. Or I go out on the road, the pollution, the exhaust, any kind of a smell comes, strong smell, then I might think. Or neighbors are cooking some very delicious food, that smell comes, then I'll realize that I have the smell sensation. Otherwise, I'll feel that I'm not even checking whether I am having smell sensation. But if I get a fall, definitely next day I'll check whether I am having smell sensation or not. Because that fall will make me to check whether my vision is normal, whether my smell is normal, whether taste is normal or not. Okay. And so these things happen. Okay, this is my perspective. If I am getting the injury means what I'll be doing. Okay. If I don't get the taste, I will not try the usual food what I am eating. I will try to put extreme tastes and see whether I am getting the sensation or not. Okay. For example, I touch and I don't feel, I'll slap myself and see whether I am feeling. Or I'll pinch myself and I'll see whether I am feeling. I will not leave it. Okay, because I want to see the extreme end of the spectrum, not the regular ones. I am regularly eating chicken, for example. The same chicken, if I don't feel the taste, I will not diagnose that it's a problem for me. In that chicken, very spicy chicken I take, that also I am not feeling the taste. Then I will feel that, okay, or whether lightly I am able to feel the taste. Okay. So what level of impairment, whether it is a total loss of sensation or is it impaired sensation. Okay. But either way, the patient has taken a treatment. Okay. We are not aware what medications were given. It was prescribed by an ENT physician. And subsequently his smell and taste has improved. It has got better. Okay. Which actually patient did not notice that it has got actually better because he started developing newer symptoms. Okay. It's like, for example, if I get bloating, I was taking medications, then the bloating started. Means whether taste and smell, it has recovered, how much it has recovered. Okay. Apart from all these questions of complicating the issue, the treatment already I have told. Okay, because treatment can be from anywhere. And also, the bus tickets will be available even last day. If tomorrow I have to travel, it will be available today also. And whatever happens during the journey, you can get down on the road, take a cab, take another bus. You always have alternative options. So there are treatments which are like that. The train ticket, you have to book at least 1 month before. You should go to the station also much ahead. You have weight limitations. You cannot carry so many bags in the train. You can no weight limitations, but bags number is there, size is there, the limit is there. Bus, no problem, you can carry. And the same way, here you see that the flight, you have the weight limitation also, size limitation also, security reasons also, and you will have to book at least 2 months before the journey if you have to economically match the other options. And you don't have an alternative. If the flight gets cancelled, the whole thing is gone. You just sit in the airport and nothing is there. Okay, it's very tough to change your journey when you have taken the flight. Okay, Train, if it interruption in the journey in between anything, you can try to take the bus, okay, or maybe wait for the other train with a delay and all that. But the bus is the most easiest, okay. But you also know bus will take you only specific distances. It won't take too much far, okay. It's not Australia where you have buses across the country. In India, the buses will go only 8 to 10 hours. Okay, they won't go more than that. And that 8 to 10 hours is thanks to the bad roads. Okay. And whenever I tell the extreme example, in the bus, whatever accident happens, the extreme accident happens, still you have likelihood to be in shape. Okay. In shape means your body will reach as it is, at least. People can identify who you are. But in the flight, you might think it is faster. You might think it is more convenient. But if something happens, they will not get anything. They will just take the sand whichever is there beside the dead bodies, and they just take that as ash, and then they perform the cremation, whatever, okay, as a personal satisfaction. Nothing remains from flight. Train, half will remain, half will not remain. Okay, so it's something like that. So adverse events are also like that. When you are trying to have therapeutic options, always see, what you are skilled at. Okay, what you can best do, what you are trained at. Follow that principles. If I have to book a bus, means there are some procedures to book a ticket in the bus. How you have to go, what you have to do, everything is there in a bus. There are some principles of traveling in a bus, which is totally different. Even washroom, for example. Before getting into the bus, you will go to the washroom because bus does not have a washroom. So the same way train is there, it has washroom. So there are different principles. You can lie down in the train more conveniently. And the bags which you take have to be more careful. You have to be in the train because it will be looted. In India means. Okay. In the bus, less chances of getting looted. So everything has a principle. Flight, baggage never gets looted. But many people will have that nausea, vomiting, all the discomfort in the flight. And if you have to go to the washroom, you should be prepared to stand in a queue because there is nothing in India without a queue. Okay. If there are two toilets or washrooms or restrooms which there, one with the queue and one without the queue, people will stand in the queue one only because they think only that washroom will work properly. That's why there is a queue there. The other one which is without the queue, nobody will even open the door and see. Okay, so that is the engrammed experience. Okay, what we all have. So what I'm trying to tell is your skill application, your treatment over a period of years in so many cases. Although this case is outside the spectrum, if you want to still treat among these options, which ones can be applicable, which one cannot be applicable, which one may be contraindicated, which one may not be suitable. No other outside world person can come and tell. The passenger only has to decide. If the passenger is a 5-year-old child, parents can decide. Okay. So it's like not knowing anything. Okay. So because a small boy cannot decide between bus or train or flight. Okay. So for him, nothing. Okay. No problem. Bus also he'll cry if he wants to pass urine, and we have to stop the bus. Okay. There's nothing that can be done. People have this nausea, vomiting. They don't go in the train. They come in the bus. They make the bus to stop. Okay. Everyone will be looking like, why is this person causing inconvenience to everyone? When you know you are vomiting means why you are coming in the bus. Go by the train now. They will look like that. Okay. No one will think that our own loved one has the same problem. What will we do? Okay. Nobody thinks like that. Empathy. So what I would like to say, actually as a summative sentence, is the therapist has to find the way, because it is not like just what to say. It is not a kind of. But when I asked Dr. Sujanya, you can see that she did not tell anything about this case. She told about a similar case which I treated. I had that experience. Okay. She can only talk about what she had seen, because she can't give a solution for this case. Okay. At the same time, all that is there is only in the hands of the therapist who is with the patient. Okay, so that is the only person who can decide best. Others, all others, we just say what we actually assume, presume, or we are suggesting or whatever, but we cannot tell towards that case specifically. But at the broadest pathomechanical principles, which I have highlighted in the cranial course, the visceral course, in every peripheral somatic musculoskeletal course of the AOMPT is only one thing. Find out whether the problem is mechanical. This is the bottom line. The mechanical problems will change with positions, it will change with movements, statics and dynamics. So that means sitting posture, my taste is different, my smell is different. Supine lying, my taste is different, my smell is different, or my bloating is different. Standing posture, different. Supine or prone is different. Right side lying versus left side lying, it is different. Then only it is mechanical. Because what is not mechanical, you cannot treat it mechanically. Mechanics means I am telling the physics mechanics, not we treat manually. Okay. But
The biomechanics.
this is the question that you need to clarify. People with headaches, always you will find that they have a comfortable position, where that position is the least headache is there. And that position will vary from time to time, but they will have one position where least headache is there, which automatically. Okay. So, and that relief position has to be analyzed, whether he is getting relief with the same side lying, whether he is getting relief when he is closing the eyes, because some people have relief of headache when they close the eyes. Okay. Whether they get the relief when they listen to a music. Why? Because the role of auditory, role of visual or vestibular if it is with the upright posture against the gravity, supine to sitting, if there is a difference. So every system we come into the picture, we bring it, our pathomechanics into the simplified breakdown of statics and dynamics. If you do not ask this question to the patient, we are not a pathomechanical or we are not an AOMPT and PT. Because shoulder pain, does the shoulder pain change with different postures? Is it constant throughout the day? If it is throughout the day means when it is less, when it is more. That is what is mechanical. Then only you are going to treat. If it is constant pain and it is not at all changing, you can't treat it. If you are thinking of treating, you are taking a step outside your boat. You should know swimming. And you should also have another boat beside you. That is the physician, to actually be in high confidence that yes, okay, whatever you feel, no problem. Let's see. Let's get this patient out of the problem, like that. So that the physician has to give you the free hand. Because here you know the system. If physicians are not in the picture and anything that happens, you just treat the cranium and tomorrow the patient gets a stroke. Leave about whether you can excuse yourself. Even before that, the relatives will come to beat you. Okay? It will not be for the clinician in this example, but other clinicians will get. Definitely I will get. Okay? If anything I do on a patient here and something happens. Okay? So I have to see that how I protect myself and my profession. So I can't go beyond that into, I have to give a hand to someone who is in the water. I should not fall into the water. Okay? I should see that I'll be able to pull that person up. If he is heavy enough and the current is so heavy, like the floods in Himachal, I give the hand means I will also go. Earlier one man was shouting, help, help, help. Now two men will be shouting, help, help, help. Okay, that's the only difference. So we have to be very, very clear about this. Okay, and sensory nerves like olfactory or the tongue, all this, they have some amount of response to mechanical stimuli like touch. Olfactory nerve, we have seen techniques of how intranasal techniques can be done for the cranial nerve massages. We have also seen for the tongue, the sensory nerves, how different sensory stimulus can be given to the patient in different portions of the tongue, sensory re-education, or giving that sensory discrimination training. Eyes open, eyes closed. Because we don't have a sensation in the hand, what do we do? Okay. We actually try to re-educate that sensation. If you know how long you have to try these methods, I cannot tell the answer. But if there is a very good participation from the patient's volition, the willpower, if I start memorizing that a particular object, the smell of the paint, okay, even I was not feeling it, but I am described that the smell is like another relatable object, like it smells like mango, okay, somebody tells me, I can remember what is the mango smell, okay, I will relate the mango color to the yellow color, and then I will try to remember what I can do, okay, so it smells like mango. I'll bring the memory of the mango smell whenever I am smelling this. What I am trying to tell is it is under my motor learning abilities how I actually re-educate myself. Right? Are we back online? Is Ritu ma'am offline? I'm seeing Sujanya moving. I am visible, Sujanya?
Yes, sir.
Okay, okay. So these I keep as considerations. Okay. We have cranial nerve techniques specifically for olfactory, specifically for glossopharyngeal. We have for the facial. But ultimately, mechanics, what we try to see is whether the smell alters with the positions and movements, one thing, and the next one with the muscles contractions. Although it's a neural symptom, okay, try to associate the muscles. Try to see whether what is called as facial muscles expressions, whether they change make the sensation better or less. One way or the other you will find. And even the tongue muscles, tongue position, or the muscles of the, that lower part of the face, yeah, the jaw, tongue, all that suprahyoid muscles. Okay. It can be even palpation of a particular muscle which will improve the sensation. When the stimulus is already kept on the tongue, okay, and the subject is not feeling, if it is candy, for example, eat the candy, no taste, evaluate tissues, find the hardness, compression. Hardness is just out of 10. I'm which goes 5 out of 10, the discomfort level. And at the 5 out of 10 when it is there, again I keep the candy. So that means I am evaluating a myofascial influence on the dysfunction. Okay. So whether a myofascial system or tissues can help this patient, treatment based differentiation, or it is involved pathomechanically, both way. Okay, whether facial expressions, because these are all related nerves. If there is a weakness in any of these muscles, you know nerve involvement is much bigger, because it's not just the taste of the tongue, it is also weakness of the muscles. And you see that the weakness in the lower half of the face, you might think about upper motor neuron lesions of the facial nerve. If it's only one side of the face, then you will think of lower motor neuron. So this all comes parallelly. Even if you don't follow a performer, you just see that pathomechanics. What you want to do means, first is we try to relate between the symptoms. For example, you give a perfume, in a wisp of cotton, you have put a particular liquid like eucalyptus, okay, so which has that intense smell, fragrance, okay, so you can keep that. And you can also see that whether the smell sense stimulation is given, that time whether you are able to feel the taste, so you keep the candy. Okay, so there are different problem solving which we have explored limitlessly in the cranial course. Okay, what we have to see here is an example like nasal olfactory stimuli improves the gustatory sensation. It's like hearing improves the speech. Okay, so these are all sensory and motor like that. And the same way, gustatory stimulus improves the olfactory sensation. Okay, so reverse also we check. Hetu ma'am will rejoin. So we have different options to actually experiment to see that which stimulus is actually can be used as a treatment. If I give olfactory stimulus, that improves the taste. It's not improving the smell, but it's improving the taste. I give the gustatory stimulus, that is improving the smell, because the smell and taste are interrelated. You get the appetite by that smell. Okay, when the chicken is cooked, you get the smell. I tell the example of chicken, which both of you will not be relating it at all. But no, contextually, that automatically creates the salivation. I'll be waiting for the neighbor when they are going to give me the chicken. In my case, it's my owner. So, this is the simple problem solving which we are telling. So that means C for positions, C for movements. The movements can be neck movements. You change the head position, head movement, then the sensation is better. All this will clearly tell it's mechanical. Even the upper cervical spine example, what Dr. Sujanya was mentioning and describing, there is no extended thinking to check cervical range of motion. She just palpated, she checked the mobility, she found the C1 is stuck, and then the suboccipital muscles in tension, adhesions, and the upper dura mater. So various releases, it would have definitely helped the patient. But what I'm trying to tell is as a screening, okay? Even keeping the tongue on the palate, whether smell becomes better, okay? So neck rotations, definitely, or upper cervical movements, they're totally different from lower cervical. Flexion rotation test, which is upper cervical. Various things can be done, and limitless opportunities are there, because human body is like a world map. Where you want to go, where from you want to start. You can start from anywhere in the world. It depends on where you are. So patients might tell that past history, I had knee pain. Then you can start from knee also. Patients might tell like irritable bowel syndrome, okay, what the presentation where indigestions, take particular type of food, diarrhea, take the other type of food, constipation. So these kind of things come. Again, there are also you are going to start from visceral. So here in this case, the visceral came much late, but the past history, maybe a visceral problem might have been there. Okay. It's maybe a simple appendectomy surgery. It could be an enlarged prostate. It can be a combination. Anywhere in the body, anything can affect anything because it is a single unit. And it is the wonder of nature that the homeostasis tries to balance all the systems and keeps the body functioning going on. Many people have more than 10 problems, but they're still functioning. Other people, they have one problem, they cannot function. So that's the difference. Okay. So it depends on their homeostasis. Okay. And mostly you see that a man, when they have one problem itself, they'll get stuck. Okay. When that problem goes to an extent which stops them from doing other things and they get stuck. Women live with 10 to 15 problems. They can manage any number of problems. Okay. So this is a general individual characteristic of gender. Okay, gender-based characteristic. There are exceptions everywhere. So 90% I am talking. So what I am trying to highlight is in the pathomechanics, always you see articular, myofascial, and neural. What we call it as structural interdependence. One structure to another structure to another structure. So joints to joints. But this is cervical to the face, regional interdependence. Okay? Because face is one region, cervical spine is another region. Upper cervical to lower cervical also is regional interdependence. Okay? In a patient who has respiratory symptoms or dysfunctions in the history, I will use thoracic spine. I will use the rib cage. So that means that is also regional interdependence. And then you come to the picture of cranial. I told you that I will not prefer to do because there is a history of trauma. I am not going to touch the osteocranial part. But the myofascial and neural, definitely I can do my best. And myofascial, I can assess by muscles activity, facial expressions, or the muscle contractions, resistance, isometric, whether that changes sensations, or if I find a visceral, in the visceral palpation, I find abnormal tension or discomfort to the patient in the abdomen, whether that abdominal dysfunction changes with even cranial. What we are seeing as the triangle, the cranial, visceral, and somatic. Okay, we are not able to directly address the cranium with osteocranium, so we use myofascial and neural. And then cranial, primary, you want primary condition cranial. Before touching that, there is a visceral symptom. So through the viscera can we treat the cranium. Whether visceral palpation, visceral techniques are influencing the cranial symptoms. And the same way, maybe the same will apply to sacrum to cranium. In the craniosacral therapy, you might give sacral pressures and see the effect on the dura mater or on the suboccipital tension, okay, or the headache, which was a cranial symptom. So these are just different perspectives to the same thing. Somatic, as of now, the history did not reveal any major somatic symptoms or history, but there will be something, because considering the age, definitely a back pain or a neck pain is something which is an eventuality. Nobody can be an exception out of that. If we think about this cranial, visceral, somatic, the triangle, definitely we can clear multiple aspects. But we did not ask all the questions. We just have to see that to tell that you can, another route to start the treatment is the autonomic nervous system, which Ritu ma'am already tried on another patient, which is like sympathetic nervous system, hyperexcitable. So I just treated the sympathetic nervous system and I saw how it works. Or in her question itself, when she described the case, she asked me whether I should start from sympathetic or parasympathetic through the vagus. Because viscera is involved, vagus can be used, or even the pharynx if vagus all these are extended options. But ultimately what I will do is the same thing. Positions and movements I will never forget. Whatever happens I will not forget. Because this is pathomechanics. Where I have to start from means ask the question this only. Whether it changes with positions or movements. Put the patient in different position, different movements. In front of the physician. Confirm that. I find that left side lying is able to hear better. Smell better. Taste better. Compared to the right side lying. So that means I'm going to use this dynamics. The left side line is feeling better. Why right is not able to feel. Okay, so that analysis is important. Which muscle imbalances are the right and left? Which neural? Even taste also. Whether it changes with upper limb position. Neurodynamic positions. You keep the elbow like this and you check the taste. Keep the elbow and then check the taste. All these are highlighted in our courses, the cranial course. Neural pathomechanics you check by this only, neurodynamics. If the craniosacral also dural tube release is there, the side line, where sacrum to occiput, dural tube release. That is like a side lying slump only, the slump test. But in neurodynamics, we recommend nerve sliders. Sliders are more gentler, easier, not the elongation or the tensioners. So how in the sliding position of nerves, or you give 4 to 5 sliders, recheck the taste. Whether it is a slump slider or it is the SLR, whatever. Point here is how you are getting the, if the lock has to be opened, you have to try every key. But which key you will try? You will look at the lock, the keyhole, how it is. That keyhole, how it is, you will see keys which are matching the keyhole. Inside we don't know, but at least the entrance has to be matching. If the keyhole is like this means, V-shape means, we will take a key which is V. And that only can go in. So, articular, you are doing, then it's only cervical or temporomandibular. Whether you want to keep the jaw deviated and then see the sensation improves. And eventually you know that jaw deviation and then the sensation improves means trigeminal. Neck rotations, again it can be trigeminal. Facial nerve also can be influenced by neck rotations in addition to the facial expression. So facial expression itself will influence facial nerve. If I am smiling and then I am doing this, it's the facial nerve which I am loading. So these are all, of course, what I have described now is only an outline because Instagram is not going to be a solution. But the course definitely is. And every course, ours begins with pathomechanics. And we always start with statics and dynamics, positions and movements. We see articular differentiation, myofascial differentiation, neural differentiations of symptoms. If multiple symptoms are there, we see symptom influence of one symptom on the another. If multiple dysfunctions are there, we see dysfunction, one influence on the other. What we call in pathomechanics as structural interdependence, articular, myofascial and neural. Next one is regional interdependence, one segment to another segment interdependence, and the functional interdependence. All the three are pathomechanics. So functional interdependence is what? Taste and smell. So this is what I told. Keep a stimulus for the smell and see whether the taste improves. Keep a stimulus for the taste and then see whether the smell improves. This is functional interdependence. One function to another function. Standing, supine, sometimes 24-hour variations will be there. Patient not able to feel in the morning, but able to feel little bit towards the evening. Digestive symptoms are more when he eats the home food. Restaurant means no problem. We do not know. Or home food, no problem. Restaurant means more problem. Anything can come. All this might have started after he had a party and he had food outside. So it may be an unrelated problem also. The visceral problem may not be a parasympathetic
Relatable.
dysfunction. Yeah. See, craniosacral dysfunction usually manifests as parasympathetic impairments. Because you treat the craniosacral system, you get the parasympathetic outflow normalized. Because the parasympathetic outflow is at the craniocervical and the sacral outflow. Rest of the cervical, thoracic and lumbar all are the sympathetic outflow.
Sympathetic.
So you treat
It's all
upper
about rest, digest and heal.
Okay. So it has helped the patient. A vagus neurodynamic test as a slider might help the patient. But before that, I want to understand the patient body. I will, but I will not do it all alone. Eventually, after clearing the ethical aspects, communication, emotional, medico-legal, any extent, and then only I will do. Suggestion-wise, if you suggest another physician, it's not going to end at all. We clearly know that no single therapist is the best therapist in the world. Okay? No single physician is the best physician in the world. Why the patient got the cure at your hands? It is a matching of situation. How our decision making, how their dysfunctions, everything. There's a communication. There's a placebo, which the patient expects or believes that the therapist can cure me. It will cure. Because here you see that Reiki therapy is there. In fact, to highlight that Dr. Sujanya's own sister, she is a Reiki healer. Okay, Lavanya, she is at New Zealand. I saw
She's
her in
in
the bio.
Bangalore.
Yeah?
She's in Bangalore.
Okay, but she said that yesterday that she is in New Zealand.
No, she wrote that as an affirmation for Ritu ma'am, that if you put a block saying, I don't know whether I will be able to go, so she wrote that affirmation for Ritu ma'am that she should think I am in New Zealand, so she will be in New Zealand soon.
Okay.
Same
I thought
goes
Lavanya is.
that way. No, Lavanya is in Bangalore.
Okay. If you are in Bangalore, you can be anywhere in the world.
That's true.
Absolutely. Okay. So Reiki, these are energy-based methods. And we never know what is the mechanism it works. Okay. But definitely we can be guaranteed that there will be an altered magnetic field. If you are seeing the biomagnetic field, the body as a object of magnetic energy, okay, and how we are aligning ourselves with respect to the Earth's magnetic poles, or how particular postures only we get the sleep. We keep the head one side. If we keep the other side, we won't get the sleep. Okay, or you just have another electronic item somewhere behind your head, you may not get the sleep because it will interfere with the magnetic field. Okay, what you are actually having. So there are a lot of things, whether scientifically proven or not. There are journals of Reiki which tells that Reiki is the most advanced and most effective technique. Same as how osteopathy journals tell osteopathy is the best technique. Physical therapy journals will tell physical therapy is the best technique. Okay, and if we start a journal, our journal, all our techniques are the best. Okay, ultimately I don't rule out that bias even if it is with me. Okay, because you as a clinician should have that thinking that everything can work. Okay.
Yeah.
At the same time, anything can go other direction also. So how do you protect yourself? How do you actually clarify your stand? Okay. Upper limb positions, neurodynamic positions changes the sensation. Definitely it is neural, cranial nerve. After that, whether you want to target the maxilla, target the nasal bones or target the base of the brain, spinobasilar junction, and give an osteocranial technique, definitely you have to get clearance from the neurosurgeon because there's a trauma. If you don't want to do that, it's different, but I will not do without that. Okay. So remember that the example, like cranial, visceral, and somatic only, the bus, train, and flight. Okay. So there are things which will take you faster. At the same time, it is like more risky. Okay. In India nowadays, trains are also more risky. Okay. Everything, there is a bit of risk.
Everything.
But what you need to share is the fundamental principles, what you actually follow. Okay. Remember that those principles were also made by man only. Man or woman, whomever, human beings. So remember that it is also open for modifications, and you should modify it according to that particular patient, because you as a clinician is the boss. Okay. That innovation and the creative thinking, you should use it to help the patient. Okay. It's not like what is described in the literature, what you got trained only is the solution. Okay. You will have to go beyond that. So that's why I say the initiating point can be anywhere, because the human body is such a magical gift, okay, that God has given. Okay. So at least humans can communicate this much. Imagine if the same is had by a pet animal. It's very tough. Okay. You might understand some of the cues, you may not understand many things. You might palpate and observe and see what is the reaction. You will be more deeper concentrating on the body responses, not on the verbal, whatever the patient is telling. So what I'm trying to tell is, keep the verbal thing aside and listen to the body.
Yeah. Be intuitive about it.
Because if you are thinking about what the patient is telling, it's a dead end. Okay. Even in Sujanya's situation, she would have seen that, okay, the tissues are abnormal. Okay. Let me treat it. Okay. So that she saw the body, how it spoke to the fingers, how it spoke to the hands. That is the communication. Okay. Which actually is the keyhole. And then you know which key will fit into it. Okay. So that should be the direction there. Whenever there are multiple symptoms, always see who is the boss of the symptoms. Which symptom is the boss. Okay. If all three are not the boss, means there will be some other symptom in the past which will be the boss. Okay. Something has to be there. So there's nothing that is out of probabilities. Okay. Many people have different strategies to coping with symptoms. Some people live with the symptom. Okay. They don't mind it, and they see, for example, the same symptoms you tell to another people in India, they'll tell bloating and all, no problem. Irritable bowel comes and goes, no problem. Okay.
They actually take pride in. Yeah, they actually take pride in a loud burping, annoying the world around them. So yeah, acidity is not a big deal, but they forget that how much of insufficiency they have got in their lumbar spine, which is supplying or the thoracic spine, which is supplying around the organs around the abdomen. So one of that similar case I can relate. Somebody came in for their constant headaches associated with, and then when I investigated, it came up with acidity and all that. And because I do lymphatic work as well as neural work, it ended up, I think in the third or fourth session, I had to do lymphatic work on them around their abdomen, and it cleared back pain for them because they suffered from constant constipation for 7 or 8 odd years. So you know how it could if you don't pick on that symptom, you're not actually going through the source of problem. You can't stick yourself just to a set of formula. It doesn't apply to everybody. So
Exactly. That is the reason why our courses, we have opened up that don't be a protocol-based technician, okay? Be a patient-based clinician, okay?
And
So
this
on
is
top,
what attracted me to do some courses with you too.
okay, so that is where this pathomechanics also we are expanding into psychological domain, the nutrition physiological domain also, because without that we cannot address the physical part, okay?
Yeah.
So,
A lot of neurological like cases that I see, I've jumped into the food and diet part of it, because if you don't nourish your nervous system, you are low on your vitamin Bs and vitamin Ds, you're not actually going to complement the therapy. So I tell this right from the first session. So if you are neurologically dysfunctioned, these are the things that you should be adding, eliminating from the diet. The choice is yours. Not promoting veganism or vegetarianism, but I would just tell them you've got to add these more, because that is going to enhance the quality of life in you, and it will complement my therapy, and it will accelerate our program to get better, rather than you just keep coming and paying me in dollars, and it doesn't work that way. So you got to complement things and work hard with me and be a partner in the journey.
so let's listen to Ritu ma'am on what she had actually inferred. Yes.
Yes, sir. Yes, as per your guidance and what we are learning from AMPT for after the today's session, what you have explained about this case, now it is something is very clear for me that how we can move. If I want to move for this case, first thing is to take the permission or the guide with the under the guidance of the physician or the neurosurgeon or whatever that from where that the patient is taking the treatment. So their clearance is very, very important. Either I am moving towards the cranial versus the visceral versus the somatic. But as you have guided me that yes, we can go through the somatic fiber first, that where we can check with the myofascial component, the muscle contraction, active contraction of the muscles. Then we can move through the viscera. We can, because now we are not moving directly to the cranial. Now we can take the route, which can be, because when we will treat the somatic, maybe it can be give relief to his symptom in the cranial part. It can be the positive sign that yes, we are treating them. Or if I will move towards the visceral, it can be relieve the part of the cranium problem. So this we can check as a treatment plan, and it will, I think it will never worsen as if we will follow the right way of patient-centered approach, and as well as the movement and position, static versus dynamic, that in which position is the relieving factor and which is the aggravating factor is always our first priority to check our patient symptoms. So that I will definitely see all the position, all the movement testing, or the changes of the position or the interdependence, either the regional versus the functional interdependence. That is very, very important part here to check the patient symptoms. So by this we can move it, because we know that the cranial neuromanual therapy, which we learned from last year 2022, that has given us a very, very clear view. But after that, the osteocranial manual therapy, that has added a new point in that how we can move into the cranium through the all the bones, all the sutures, all the joints, that also. But here, because the case is the trauma, the fall is there, so we cannot jump directly on that place. So for that, it is very, very clear, yes, clearing guidance that how we can move, how we can make a roadmap to go towards that, so that we can slowly, not so fast, we can take anything. We can take a slowly route, and one by checking the positioning, movement, myofascial component, neural component is very, very important, because when we give our treatment as a myofascial component, as a AMPT member, we know that orthomyoneuromanual therapy, which is the flag, the priority flag of the AMPT, where we think all the structures, either the articular, myofascial, and neural, in the simultaneously. So this somatic fiber will give me the clue that either my patient is improving with the articular myofascial. Here, articular also we are not going to treat, but myofascial and neural, we can go through that. And then we can think, because the visceral problem, visceral manipulation is needed because the patient is having a, last year they are having a problem related to liver. So we can add on the visceral manipulation is also there, and by treating the autonomic nervous system, so the parasympathetic versus the sympathetic, I can move the third step towards that also. Then I will see that what kind of the response I am getting. After that, I can take forward my step towards reaching to the cranial in the very last, because I hope and I believe in that I can, through this map only, I can change I can see the change in my patient, because this is a very right map which we are going to follow. And after the permission of the physician, if he will allow, so and he will agree with this route map, definitely I will go with this route map, and definitely I will try. I will not leave it as it is that I cannot do anything, because I know that in UMPT we can do so many things, because we have learned so many things. So it's our duty to return to the academy that what kind of the courses the sir is providing. So now it's my duty to take it back, get as a research that what kind of therapy we have used if this kind of the situation we see in the patient. So I am not that kind of the therapist that who will leave in between the patient. Definitely I will try from my side, but without permission I will not do anything. With the permission of the doctor who is taking his course, case. So with them I will talk definitely, and then I will move towards this case. So this is my commitment from my side, that yes, what I can do after the guidance of the sir and with the reference of the Sujanya ma'am, and with all the members of MT who can also give them a better view, that if they are listening this course, and whoever is listening on the Instagram, so they can also give their suggestion point of view. So for that I will move forward with this case. So thank you so much, sir. Definitely we can do so many things. We cannot leave like we will not do anything. So same thing that yes, we can trust our learning, we can trust on our instincts that yes, we can do it. So thank you, sir, and thank you, ma'am, for your
Thank you.
presence also, and your kind words and your experience with your case references. That definitely these kinds of bridging gives us a better idea that yes, what we can do more and more for our patient betterment. So thank you so much to you also, and yes, sir, as our active protocol, the patient-centered approach is always our priority that we will definitely follow. Yes, sir. Over to you, sir.
And in case if you are going into the osteocranial,
Yes, sir.
remember the first step. What we do with the stethoscope, what we do
Yes.
with the tuning fork, what do we do with the percussion hammer, how you can
Correct.
actually see the different responses in different parts of the skull,
Right.
which may not be in the cranial osteopathy courses. Okay, we have shown that in the osteocranial, that the cranial osteomanual therapy. Okay, the bigger course. Of course, it's bigger than the visceral course, which I shared
Yes, sir.
the video screenshots with Sujanya, just to give her the idea that how vast is the visceral course. Okay,
I know my head was spinning.
so the cranial is much more bigger. Okay, so it's like a pre-session pathomechanics, and we have taken.
It's a lot of effort you have put in, sir.
Huh?
It's a lot of effort you have put in to organize those modules. I was just going through those pictures that you've sent me, and I was imagining before even doing the course how much of a prerequisite prep I have to do in order to understand what you would teach in that course. So, yeah, it's quite an intense work you have laid out.
No, but I don't think Rituma Mandal did any prerequisite work. What she
No.
did was she took visceral anatomy webinars. Okay.
Right.
So which were also part of the content. Okay. So if people who are taking the course will watch the anatomy videos first, and of course they can go to the next.
Right. Okay. That's easy. Can be done.
So it is all part of the content, and all our courses we don't require any. Before that, you have to do any course. Okay. It is like standalone. Okay, every course has that aspects, but the depth of that content will be different. Okay, so it is like that. And 3 years, of course, the list of courses what I sent you is only just for an idea, but
Yeah.
the
You
courses can
have.
be customized for everything. It can be customized as per patient. It can be to any extent you can explore that. There is always courses. Okay, relevant to that, the materials all you will receive.
Yeah.
If, for example, patient is having osteoarthritis knee with a constipation, okay, these two. That means you can take relevant to that gastrointestinal in the visceral, and then take only the osteoarthritis part, and then the lower extremity kinetic chain, and the arthromyoneuromanual therapy or the in the the cranial, visceral, and somatic also. There's a cranio-viscerosomatic, cranio-somatovisceral, viscero-craniosomatic, viscero-somatocranial, somato-viscerocranial, somatocranio-visceral. 6 different patterns are there. Okay, that means it is like these 3, the triangle we told, but the triangle is actually a prism, and that prism will create white light into different lights. Like that, 7 colors are coming like that. The 6 groups are there. Okay, so patient scenario maybe today as one subgroup, tomorrow maybe another subgroup, the same patient. So that's the reason why we listen to the body rather than listening to the patient. We listen to the patient, of course, as an initial guidance, but trust the language, the body that speaks to you, to a dedicated hand. Okay, listening hand. Okay, so that's why in visceral manipulation also they tell therapeutic listening. Cranium also they tell listening. Okay, with the hand. Okay, so right, but we extend it using tuning fork and percussion hammers and stethoscopes to enhance that listening and to concretely say that there is a dysfunction. Okay,
Right.
so
Right.
right.
Hey, that will be interesting component for me to look into. The 3.
Because it gives you the concrete proof, and you can also recheck after a treatment technique how it has improved.
So
Okay?
standardized outcome measure then.
Although it is not published or validated scientifically, but as a clinical tool, you can definitely, nothing stops you from using that.
Yeah. Yeah, it's a good confirmation for yourself that you are going in the right direction.
Give it to the patient also and make them to feel. Okay, you see the right versus left, auscultating. Okay, or the neurosurgeon also can feel the difference. Okay, so everything it's possible. Right. So thankful to the internet. Today finally it has allowed all of us to complete this session. Otherwise we could have extended to tomorrow. Even if it has gone to 4 to 5 days, Ritumam will not leave us. First you solve this, then you take the other webinars you would have told. Okay. So other way, right? So we are ready to close this session, right? Huh?
Yes,
Right?
sir.
Yes.
Okay.
Yes, sir.
Yes.
Thank you, sir. Thank you so much. Thank you, ma'am.
Thank you so much, ma'am and sir. Yeah, thank you.
And especially, you listen to each other's perspective, then you become much stronger. Okay. She
Yeah,
got the
I think the
treatment.
certainty level goes up.
Okay. Right.
Right, sir. Thank you,
Okay.
sir.
All right, sir. Thank you so much for your time and thank you for
Any
delaying the session. Thank you.
suggestions? Any suggestions for tomorrow topic?
Yes,
And
sir.
Any suggestions for the tomorrow's topic?
Ma'am
Among the
will
list
tell.
of. Huh?
Ma'am will tell.
oh no, I'm a beginner. You guys can guide me, please.
No,
Not even.
I'm a
ma'am.
beginner in the AOMPT.
She'll tell in the AOMPT, in that lower limb of the A, I am just holding and standing.
That's right. I'm just like a little finger in AOM putty, that to the nail of the little finger. I've just entered that portion. So there's a lot to go. I would really work along with your guidance. And of course, when you guys come up with a webinar, there will be something for me to tell for the 15 years of experience I've got. So I might come up with a case that pops up, and I might share my, treatment plan, what I did, what worked, and what didn't work. But obviously, I'll go with the pattern of you guys are very structured and organized, so I might as well stick to your topics. That's fine.
Right.
Thanks for asking. Thanks for asking.
Any other thing in mind, Ritu ma'am? What topic?
So we can go towards the pathomechanics of how the impingement comes. So the pathomechanics related to the impingement. That we
That is
can
one
take
of
it tomorrow.
one of the what I called as a master session. First, after thoracic outlet, I think shoulder impingement, and
Yes.
of course the practical at Pune, the star demonstration session will be that impingement syndrome. Okay? To show that how even a foot can affect the shoulder. Okay, we can easily demonstrate in impingement syndromes. Okay.
Yes.
Okay. So tomorrow let's see shoulder impingement syndromes, and day after let's get on to any of the lower limb.
Yeah. Sounds good.
Friday mostly we should have the visceral webinar from Ritu ma'am. So that case webinar is there. That's of course for the visceral course at Coimbatore. Okay, to
Yes.
motivate those people, those who have enrolled in the visceral course, to because they have got the theory through 2 webinars of Ritu ma'am on Zoom,
Right.
and so they'll be happy to know when it is applied in reality how well it works around the patient.
Yeah.
So that their entry into the course on Sunday will be this Sunday. Okay, so they'll be very happy and what is called as excited.
Yeah.
Okay, to learn. Right. So see you. Bye bye. Good luck.
Thank you so much,
Bye.
sir. Thank you.
Bye.
Have a good night. I'll catch up again for the next webinar.
Sure.
Yes.
Thank you. Thank you.
Night.
Bye-bye.
I
Nighty
love
night.
your word night.
Yeah. Nighty night.
Night. Right. Bye.
Bye bye. Bye bye.